Ontario Premier Doug Ford pushed for healthcare privatization to reduce wait times and costs. Now, a new report is challenging these claims. Authored by Andrew Longhurst from the Canadian Centre for Policy Alternatives, the report uncovers hidden payments to private hospitals and questions the benefit of privatizing hospital services. Titled At What Cost? Ontario Hospital Privatization and the Threat to Public Health Care, the report draws on freedom of information data, financial analysis, and research. The findings show a significant gap between the government's reported and actual spending on private clinics. In places like Barrie, public hospitals are underused while private clinics receive more funding, despite cuts in public health care. The panel, led by Anisa Carrascal of the Simcoe County Health Coalition, included insights from Longhurst and Michael Hurley of the Ontario Council of Hospital Unions. The report also compares Ontario's situation with British Columbia, Alberta, and England, highlighting the risk of healthcare commercialization. It is a call for policymakers to reconsider the impact of healthcare privatization on public health and safety. Following is the panel discussion hosted at Barrie Public Library last week.
We're here to present the report At What Cost? Ontario Hospital Privatization and the Threat to Public Health. It's published by the Canadian Centre for Policy Alternatives. I'm here to present Andrew Longhurst. He's a political economist and the author of the report. And Michael Hurley, the president of the Ontario Council of Hospital Unions, CUPE. They are, that's the organization that requested the report. So thank you very much for your presence, and I'm not going to add much more. And sorry, I forgot to introduce myself. I'm Anisa Carrascal, and I'm the co-chair of the Simcoe County Health Coalition. I'm here also representing Natalie Mera, the executive director of the Ontario Health Coalition. So, thank you.
Thank you. And Anisa, you're, I think, going to provide some local context after
Yes.
Michael and I speak. So, thank you. Great to be with you. Thanks for having us in Barrie. So, I'll give an overview of the research findings and happy to answer questions after all of us speak, and I'll jump right into it. So, this report really looks at the policy and legislative reforms used to expand for-profit delivery of surgical and diagnostic imaging in Ontario. And the report also looks at Ontario's wait time performance in relation to other provinces. The other main contribution of this research is a financial accounting of how public dollars have been spent in these for-profit facilities, something that hasn't been done to date in Ontario. And then finally, the report provides a review of the academic research literature and the policy experience with for-profit delivery of surgeries and diagnostic imaging, and looks specifically at what the evidence tells us reduces wait times and what the evidence tells us doesn't reduce wait times. So just a little bit of context to begin with. In August of 2022, the Ontario government announced that it would increase the number of publicly funded surgeries and diagnostic procedures performed in for-profit facilities. The use of public funds to perform procedures in for-profit facilities is called outsourcing or contracting out, or simply for-profit delivery, and this is a form of healthcare privatization. In January of this year, the province announced a phased approach to expand for-profit delivery, beginning with outsourcing more cataract surgeries, as well as MRI and CT scans, and colonoscopy and endoscopy procedures. Then in May of this year, the government passed new legislation to encourage the growth of this for-profit sector. The legislation, this is Bill 60, established a new legislative framework for for-profit facilities, which have been called independent health facilities since the 1990s. And what this report really responds to is a number of arguments that have been put forward by the Ontario government about the role of for-profit healthcare delivery in reducing wait times. But what this research report points out when we look at the wait time data from across the country is that it's especially puzzling and troubling that Ontario is moving in this direction when it in fact has much better and much shorter wait times compared to the provinces that have the greatest amount of for-profit delivery of surgeries. And those are BC, Alberta, Saskatchewan, and Quebec. So this is not to say that wait times are anywhere near where they should be in Ontario. There's a lot of work to be done, and this report identifies how the province could do that through an evidence-based strategy. But it's especially troubling that the Ontario government is moving in this direction when we see quite clearly that in many areas, including hip and knee replacements and CT and MRI scans, these are the very areas where the government is seeking to privatize them. These are areas where, in fact, Ontario performs the best in the country. We also know that these are areas, so hip and knee replacements are, as of now, only performed in public hospitals. In the last year of publicly available data, Ontario had the best wait time performance in the country. It also has had the best wait time performance for MRI and CT scans in the country, and these are overwhelmingly performed in public hospital settings. So as I said, we know that wait times remain too long, but moving in this direction runs contrary to what we see the experience have been being across the country. So the report also provides a financial accounting of public funding for surgeries and diagnostic imaging performed in for-profit facilities between 2017-18 and 2021-2022. These are fiscal years. And as of January 2023, there were 902 independent health facilities with diagnostic imaging representing 81% of total services that these facilities provide. There are 10 independent health facilities, or IHFs, that provide publicly funded surgical services, all of it being, these are quite minor procedures, and we have 3 publicly funded private hospitals that have been grandfathered in the province. 2 of these hospitals, Shouldice Hospital and Don Mills Surgical Unit, perform surgeries, and there's 1 substance use private hospital, but that's not the focus of this research. The Ontario government provides very limited public data on publicly funded independent health facilities and private hospitals. Therefore, multiple freedom of information requests were made to the Ministry of Health and Ontario Health as part of this research. Analysis of the data obtained from Freedom of Information, as well as analysis from other data sources, including the Canadian Institute for Health Information, show the following, and I'll just cover these high-level findings. The volume of publicly funded surgical procedures and medical imaging performed in the for-profit sector has remained relatively stable in recent years. However, it's anticipated to grow as the government moves forward in this policy direction. In fiscal year 2021-22, less than 2% of publicly funded surgeries were performed in for-profit facilities. And this is an important point. Ontario is not nearly at the place or down very far down this path compared to some other provinces where a larger share of surgeries are performed in for-profit facilities. And that's why this report comes, I think, at an important time, because Ontario is in the early days of embarking in this on this policy direction, and there's a moment that we have in this province to understand whether this is the direction that will actually reduce wait times over the long term. And I'll have more to say about that shortly. But this is an important point that Ontario is not yet has not yet entrenched a for-profit sector in the way that other provinces have. In fiscal year 21-22, public operating room surgical volumes were below pre-pandemic levels. And what this tells us is that staffing challenges and funding continue to challenge public hospitals in the province. And this comes despite government's plans to increase the volumes of surgeries and the staff required in these for-profit facilities. In fiscal year 21-22, for-profit surgical and medical imaging was a $500 million industry in Ontario. And by dollar value, we saw for-profit medical imaging receiving the largest share of this public funding at $458.6 million in fiscal year 21-22. And it's okay. And of these, ultrasound and diagnostic radiology or X-ray received the largest share of public payments. Ophthalmologic procedures, these are mainly cataract surgeries, were the highest volume surgical procedure performed in independent health facilities in 21-22 and attracted the greatest public payment in dollar terms. This is followed by surgical procedures performed at Shouldice and Don Mills Surgical Unit. As I said, there's only 2 private hospitals under contract to perform publicly funded surgical procedures. Shouldice Hospital performs hernia repairs, and Don Mills Surgical Unit performs a variety of procedures, at this point in time, quite minor procedures, and they received $8.26 million and $4.97 million respectively in fiscal 21-22. Payments to Shouldice Hospital and Don Mills Surgical Unit increased by 19% and 278% respectively over the last 5 years of data. And what we also, or I should say what was also uncovered in this research, and one of the main findings, is that public payments to for-profit facilities in Ontario can't be completely and accurately accounted for in Ontario's public accounts. And the public accounts are produced by the Ministry of Finance, the Treasury Board, and this is a public accounting of how Ontario public expenditures are being spent, or tax dollars are being spent. So this is probably the best way to know exactly how public dollars are being spent in the province. And what was discovered through Freedom of Information is that the Ontario government underreports those payments to the for-profit sector by 720%. So in 21-22, the public accounts report $68.5 million transferred to independent health facilities, while expenditures obtained by Freedom of Information request put payments to independent health facilities at $474.1 million. So a significant discrepancy. The final section of the report outlines the academic research evidence and the policy experience with for-profit delivery, and what reduces wait times and what doesn't reduce wait times. What we see from that literature and that policy experience across the country is that private for-profit delivery of surgical care and other healthcare services worsens public sector staffing shortages and can destabilize public hospitals. A recent evaluation of the Alberta experience, this is a province similarly focused on for-profit delivery, found that hip and knee replacement surgical wait times worsened with greater involvement of for-profit facilities. Alberta today has, based on the most recent data, has among the worst hip and knee replacement wait times in the country. And so what we saw specifically in this study of the Alberta situation is that as surgical volumes and payments, public payments to these for-profit facilities increased, we saw a decline in output of surgeries in public hospitals, and we also saw a decline in public operating room staffing levels. So again, this tells us the issue is that we have a workforce that can't be in 2 places at once, and when you ramp up surgeries performed in the private for-profit sector, you're pulling on that same limited pool of staff, and they have to come from somewhere, and they come from the public hospital system. We also see that increased for-profit delivery risks expanding two-tier healthcare in Ontario through unlawful extra billing, as we've seen in BC, in particular where a large for-profit surgical sector exists. And in BC, just to provide a little bit of more context, this is a province that over more than 2 decades has seen the large growth of this for-profit surgical industry. And in that province, in the last 5 years, BC has had the most unlawful extra billing. So these are patients being charged out of pocket for publicly insured procedures, the equivalent of OHIP insured. And BC has been trying to address this ongoing challenge. So it is a cautionary tale as Ontario moves in this direction, the more that you expand for-profit and the profit motive in surgical and diagnostic delivery, the more that you risk entrenching these unlawful billing practices that are contrary to both provincial statute and the Canada Health Act. We also see the risk that we will see the emergence of not just private facilities or private clinics, but full-blown for-profit hospitals in the province. Since Ontario is the largest market in the country, there is growing interest from domestic and US investors. And in Appendix C of the report provides emails from a US healthcare investment advisory firm that was no doubt has large institutional investors and clients that it's working for, and they sent emails to the Ontario Health Coalition, the BC Health Coalition, and the Alberta Health Coalition, asking very pointed questions about the fact that these provinces are outsourcing more surgeries, and is there going to be long-term outsourcing? What they were trying to do is put together market information to create a prospectus for potential clients that they may have. These may be private equity firms, hedge funds, US for-profit hospital chains. We don't know exactly who their clients are, but the fact that they are reaching out, the firm is called Marwood Group, they were clearly looking to understand whether investing long-term or advising their clients to invest in set up shop in Ontario and across the country is something that they should be doing. And so Ontario moving in this direction is certainly like waving a flag saying we're open for investment, and there are a lot of problems that come with greater institutional investment from large players like private equity firms when they come into healthcare. So, and specifically what that looks like for patient care is we see when we look at large biomedical studies, looking at patient outcomes among large population cohorts, we see generally for-profit delivered care to be inferior to that of care that is delivered on a not-for-profit basis. And that's largely because those for-profit organizations tend to reduce staffing levels and staffing mix, and that leads to adverse outcomes, that leads to complications, a whole number of issues that can result in increased mortality and worse outcomes for the patient population that they are serving. So these are not issues that should be shrugged off. They're very serious when they enter into the healthcare system, and the movement of the Ontario government in this direction risks really undermining the quality of care that we would see in the province. Finally, we know that when we look at the arguments that for-profit care is cheaper, we don't actually find any evidence for that in the empirical research literature. What we see in BC, in Quebec, in England, and certainly in the United States is for-profit care is more expensive when you look at the same procedures being delivered on a for-profit basis versus a non-profit basis. In Quebec, we saw a recent evaluation that came out in the summer of this year where the same procedure was more than 2 times as expensive than that which is delivered in a public hospital. And then finally, for-profit facility ownership introduces financial conflict of interest in medical decision-making, which can lead to upselling. We know this to already be an issue in Ontario. The issue of self-referrals, physicians referring to facilities they may have a financial stake in, and the risk of more clinically unnecessary procedures as there's a financial interest in performing procedures where there is not a good clinical basis for performing those procedures. These are already issues that we grapple with in Ontario, but these are likely to become more acute as the for-profit sector grows. And I will now turn just to briefly summarize a couple of the policy strategies in the research literature as well as in what we know from the policy experience here in Canada. So first and foremost, we know that Ontario doesn't lack the physical space to increase surgical delivery and diagnostic imaging. We don't lack the equipment. What we lack is the workforce to be able to perform more surgeries and reduce wait times. And so in the research evidence, what we see is that building and sustaining hospital capacity, acute care capacity, is a proven method of reducing wait times over the long term. But there has to be a long-term funding commitment from government, as well as the ability for these public hospitals to staff up and recruit and retain. You can't just turn on the funding tap and then turn it off. You have to sustain that funding, and that's what the experience as well as the literature shows us. And we know in Ontario there's a lot of underutilized public operating room capacity. And I know you're going to hear a bit more about the local context here in Barrie, but provincially we have over a third of hospitals in the province that have underutilized public operating rooms, which means that they're not working a full daytime schedule on a weekly basis. And beyond that, what we can also do is extend and expand operating room capacity by moving procedures and slates into evenings and weekends. And in most hospitals across the province, there may be one OR operating room that's used in evenings or on the weekend, sometimes none, but certainly there is a lot more capacity that could be used. Again, keep in mind, Ontarians have already paid for this infrastructure. We don't need to pay investors a premium to build these facilities. We have the operating theaters already in this province. But what we need is the commitment for funding and increased staffing. And then secondly, there is a need to implement improvements to how the public delivery of surgical services and pre-surgical services are delivered. And specifically looking at implementing what are called single entry models. This is an evidence-based strategy of improving how patients are referred from their primary care provider to a group of providers, including surgeons, who are working together at the top of their skill set and maximizing the skills that we have from other providers like physiotherapists. In the area of orthopedics, as an example, moving towards these type of central intakes we found in BC was able to reduce the number of people who didn't actually need a surgical consult by over 50%. So by reducing demand on surgeons' time for surgical consults for patients who aren't actually surgical candidates, you can thereby get patients who need surgery into surgery much more quickly and reduce wait times while also supporting them with a variety of other non-operative supports and therapies that help them maintain their health status while they're waiting for surgery. So I will conclude there and I will pass it along, I think, to Michael. And as I said, happy to answer questions at the end.
I won't take up too much of your time, but I mean, Andrew said that Ontario is doing well relative to other provinces with respect to wait times, and that's true, but at the same time, there are 170,000 people in Ontario who are on waiting lists for surgeries beyond the medically recommended time limits for those surgeries, and 17,000 of those are children. And of that total number of people, 2,500 died last year waiting for those procedures, and 9,000 people died waiting for MRIs and CAT scans. And, you know, I think we would say that this is a function of a system which has been stripped of a lot of capacity. The closure of about 18,000 hospital beds over the last 25 years has left Ontario with the fewest number of hospital beds of any province in the country or of any country with a developed economy in the world, and the fewest staff for those beds as well. And so as the population ages and as it grows, the demands it's making on the healthcare system are beyond its resources. So you would think that the government would be investing in the hospital system, but in fact in the last April budget, you know, the Barrie Hospital and other hospitals in the province were given a 0.5% operational funding increase, 0.5%. And their inflationary costs are more like 5.6% because they give all inpatients drugs free of charge, which of course they should. Physician salaries are you know, rising greater than the rate of inflation. Medical technologies are expensive, you know, and they have the normal inflationary cost pressures. So you know, they're being cut. Their budgets are being cut in real terms, and yet at the same time, the surgical centers, the private surgical centers, budgets funding in the April budget went up 212%. Which gives you an indication of the government's priorities. So even though we know that in private surgical centers, death rates will be higher. We know that the healthcare outcomes will be poorer based on studies that the Canadian Medical Association Journal and others have done. We know that the costs are higher. Andrew just referenced a study in Quebec that found more than twice as much in the province of Quebec for the same procedure done in the public sector. And we know that these facilities will steal staff from the public sector, and you can see that happening in real time in Ottawa, where a private consortium we're not sure whether they're leasing or being given the operating room space by the Ottawa Hospital to do hips and knees, but they're offering the nurses and clerical staff at the Ottawa Hospital twice their normal salary to come and work for them. And of course, it's Monday to Friday, it's 9 to 5, and if you're a nurse who's working rotating shifts and can earn twice as much, on straight days, it's only human nature that you would be attracted to that. And it has the effect of taking out of the workforce for the Ottawa Hospital, in this example, people who would be available to fill holes on the schedule there and elsewhere. So there is no rational reason why we would be supporting these investments in the private surgical centers, and we're asking the government to do what really needs to be done, which is to make significant investments in the operating budgets of the hospitals to allow them to clear the waiting list, get the patients off those, get them off stretchers. There's 1,300 on stretchers today in Ontario hospitals waiting for beds, and also to relieve the pressure particularly felt in rural communities around emergency department closures, of which we had 145 last year. So that's what we're putting as a challenge to the provincial government. So over to you with the locals.
Well, we have been compiling information from several sources from all 5 hospitals in our county that not only provide evidence to the findings of this report, but also add more questions about it. The conclusion that we have reached with the anecdotal evidence that we have been compiling, that is coming to us from our members and from people working inside of the hospitals and the members of the community, is that we're severely short-staffed, and the money announced by the Ministry of Health is but a drop in the bucket of what is really needed. What is worse, the money is often allocated directly or indirectly to private care. The capacity of our county to respond to emergencies is diminishing rapidly, with no end in sight. And this is, as Andrew has pointed out, a very important point on trying to build a system that doesn't require emergency surgical services. So all 5 hospitals in the Simcoe County have posted public warnings of ERs experiencing extended waiting times more than a dozen times since July. Some of the hospitals actually went so far as to post in their social media accounts directing people to virtual care services that are not covered by OHIP. So this is the point in which that we have reached here in this county, that you cannot access your ER services. We have also received reliable information that several MRI, diagnostic, and lab departments in the county had to close or reduce their hours for lack of staff, effectively reducing or severely limiting the provision of ER services in our local hospitals. Further evidence that the Ontario government has been consistently defunding our hospitals and allocating those funds to private companies are 2 examples that I'm going to give you right now. One is the Stevenson Memorial Hospital. An 8-bed high acuity unit was closed last year, resulting in the layoff of 13 nurses in the middle of the worst nursing shortage we have ever had in this province. Even though the clinic funding was not tied to COVID funds. In the meantime, the Royal Victoria Hospital just announced their partnership with a private company, LASIK, for a cataract clinic, moving the eye surgeries out of the hospital and into a privately run location. So far, there's no evidence this has actually improved the capacity, just moved care from public to private hands. We don't have the details of the partnership. They're not publicly, released. We don't know what the costs of this change are actually, being transferred to us. And even without, even if we had that information, we're not counting the upselling and the overcharging that the private eye clinics are very known for. We have plenty of evidence through the Ontario Health Coalition that has been compiling thousands and thousands of reports from clients that have been overcharged, upselled in eye clinics. We're not utilizing ORs at capacity in the Simcoe County. Just as an example, you can go on the website of the Stephen Memorial Hospital, and the posted OR hours are 8 a.m. to 3 p.m., Monday to Friday. We have plenty of room to improve the services that we have in our county. The problem, as the report stated today, is not that we don't have locations for surgeries. What we don't have is the staff to support and perform the surgeries. This is where the government is not investing. And the problem will be even worse when nurses and medical technicians leave hospitals to go to work in private clinics, which is already happening. We just received postings from hospital offering signing bonuses up to $12,000 for a part-time technician, a lab technician, a CT, MRI technician, because the poaching has already started. Hospitals have to offer more incentives, and we, as the taxpayers, are fulfilled. So we also heard rumors of orthopedic doctors planning to rent surgical space and resources from hospitals as private practitioners. We don't believe that's the best use of our infrastructure and human resources. Staffing issues are not being adequately addressed by the government. We have a great local example of how terrible the situation has deteriorated. The Ontario Nurses Association, ONA, requested early this year an independent assessment committee, which is an independent expert panel, to evaluate the staffing and working conditions at Collingwood General and Marine Hospital. And the AAC report concludes that recruiting strategies will do nothing to improve staffing gaps without immediate action to retain the nurses they already have. This suggests very clearly the trend of nurses leaving the profession altogether or moving to work in agencies, which are private concerns or private clinics. The report also provided over 130 recommendations to address this issue. We will be very curious to know how many of these recommendations have been actually implemented. We believe the Ontario Ministry of Health is willfully neglecting the health of Ontarians, but failing to address the real causes of the current healthcare crisis. This must stop now before more lives are lost.